Okay, so today's lecture is on multiple myeloma, myeloproliferative neoplasms, and myelodysplastic syndromes. Right. Sorry. We begin with multiple myeloma first. So this is actually a malignancy, also B-cell malignancy. Characterized by abnormal proliferation of plasma cells, and it is able to produce these plasma cells. They are able to produce a monoclonal immunoglobulin, which is the M protein. On statistics, there are approximately 4 cases per 100,000 population per year, so it is not that common. And this statistics is in US. So the median age at diagnosis is 66 years old, and it has a slightly male predominance. Okay, on clinical findings. Okay. The signs and symptoms of multiple myeloma. Okay, the patients might have anemia, renal failure, okay, bony lesions, okay, with pathologic fractures and associated pain. Okay, this one the clinicians can diagnose through X-ray. Hypercalcemia, okay, the patients might suffer from hypercalcemia and also recurrent infections. All right. This is a picture, okay, of a pelvis. Okay, picture number 1. A pelvis of a multiple myeloma patient. Okay, so you can see that this pelvis contain numerous lytic lesions. Okay, without reactive sclerosis, which almost have soap bubbly appearance. Right. The ischia. There are also lytic lesions in both proximal femora. And figure number 2, this one is showing a characteristic multiple myeloma of punch out lytic lesions in the skull of a multiple myeloma patients. So you can only see this through diagnostic tools such as X-rays. Okay, this is the laboratory features of multiple myeloma. They can first be detected during routine wellness testing, showing up as for protein as an abnormal total protein, okay, and elevated calcium, low white or red blood cell count, and or moderate to large amounts of protein in the urine. So this can only, I think, you can find it when you do blood checkup actually, and also urine analysis. And also, okay, on the M protein, the presence of serum M protein in 24 hours urine collection is also one of the diagnostic characteristics of multiple myeloma. And upon immunological findings, immunological investigations, the immunoglobulin G is found to be much more concentrated than immunoglobulin A, than the light chains, and also IgD, E, and also M. Okay. This is after this is to refer the diagnostic criteria. There is an increase of plasma cells more than 10% in the bone marrow aspirate and also biopsy. And these plasma cells, they often have immature morphology. And the patients present with normochromic nomocytic anemia. The erythrocyte sedimentation rate is more than 100 millimeter per hour. And there is a roll formation in peripheral blood smears, which is appearance of stacked coins upon blood staining of multiple myeloma patients. So this is the roll formation. It occurs when red blood cells form stacks or rolls. And this is due to either an artifact, which is a result of not preparing the blood smear soon enough after placing blood on the slide, or it can be due to presence of high concentrations of abnormal globulins or fibrinogen. So one has to be very careful in diagnosing this because it can be due to artifact. So this formation of the red blood cells is found in multiple myeloma and also microglobulinemia. Right? Okay, so this is the diagnostic criteria. A myeloma protein is actually an abnormal immunoglobulin fragment, or immunoglobulin light chain that is produced in excess by an abnormal clonal proliferation of plasma cells. Typically can be found in multiple myeloma patients. Other terms for such a protein are M protein, M component, spike protein, or paraprotein. So you can find that different versions, different terms of M proteins in the textbook. So here I use M spike. Just now I use M protein, so it's the same thing. So the major criteria is the bone marrow plasma cells is more than 30%. The monoclonal M spike appears upon electrophoresis, and there is a presence of soft tissue plasmacytoma. Please have a look on this term in the textbook. Okay, and there is what do you call turutan? I'm not sure what that is. Of immunoglobulin in the patients. Immunoglobulin G is more than 3.5 gram per deciliter. A is more than 2 grams per deciliter. The presence of light chain is more than 1 gram per deciliter, and all of this can be found in the 24-hour urine of the samples of multiple myeloma patient. Minor criteria is bone marrow plasma cells of around 10 to 30%. There is a presence of M spike upon electrophoresis, but less than in major criteria. There is a presence of lytic bone lesions, and the normal IgM is less than 50 milligrams, A is less than 100 milligrams, and IgG is less than 600 milligrams per deciliter. So you can see that lytic bone lesions is not present in all multiple myeloma patients. Okay. So this is the risk group. This is a revised international staging system. So multiple myeloma is staged using race based on 4 factors. The amount of albumin in blood, and the amount of beta-2 microglobulin in the blood, the amount of LDH, lactate dehydrogenase in the blood, and the presence of specific gene abnormalities or cytogenetics of multiple myeloma. Right. So you can see here in those with those who are grouped in group 1, the serum beta-2 microglobulin is less than 3.5 milligram per liter, and they have albumin level of 3.5 gram per deciliter or greater. Cytogenetics are considered not high risk, and the LDH levels are normal. Okay. For stage 2, they are not categorized as in stage 1 or 3. For stage 3, the beta-2 microglobulin is higher, 5.5 milligram per liter. Cytogenetics showing that they are considered high risk, yeah? And or the levels of LDH in their blood are high. Okay, so for prognosis, in multiple myeloma, beta-2 microglobulins is a powerful prognostic factor, and the values of less than 4 microgram per mil, microgram per mil, is considered a good prognostic factor with a median survival of 43 months. Yeah, whereas those presented with cytogenetical abnormalities, yeah, of chromosomes and beta-2 microglobulins of more than 2.5 microgram per mil is considered as poor prognosis. Yeah? Okay, so we are done with multiple myeloma. Do you have any questions so far? I think everything is on my slide, yeah?
No.
No, okay. So please sign in your attendance, yeah? Make sure you have your friends informed about the class. I think this is the last class for hematology. Make sure they are informed. Okay.
Yes.
All right. Okay, so I move on to the next malignancy, myeloproliferative neoplasms, MPN. So MPNs, they are blood cancers too, which occurs when the body makes too many white or red blood cells or platelets. So this overproduction of blood cells in the marrow can create problems for blood flow, and then it will lead to various symptoms. They were called myeloproliferative diseases. So you can see in some older textbooks, they use myeloproliferative diseases. Until 2008, when the World Health Organization, WHO, reclassified them as cancers, and then they are renamed as MPNs. All right. So there are three main types of MPNs: polycythemia rubra vera, or polycythemia vera. Second one is essential thrombocythemia, and the third one is primary myelofibrosis. Okay, or some textbooks they just call it myelofibrosis. Okay, so polycythemia vera, okay, PV, is a condition characterized by increased number of red blood cells in the bloodstream, and the affected individuals may have excess white blood cells and also platelets. So these extra cells and platelets will cause blood to be thicker than normal. So as a result, these abnormal blood clots, they are more likely to form and block the flow of blood through arteries and veins. Okay, so this will give problems to the patients, and their blood are concentrated than normal. So individuals with PV, they have higher risk to get deep vein thrombosis. Okay, I think you have learned on DVT before, correct? Have you learned on DVT before, deep vein thrombosis?
Yes.
Okay, so I don't have to explain further on this. So these affected individuals of PV, and they also have an increased risk of heart attack and also stroke. This is due to the blood clots that have blocked the heart and also the brain of these patients. Okay, so these are the clinical findings of patients with PV. Okay, they have headaches, dyspnea, blurred vision, night sweats. They can also have this plethoric appearance, okay, caused by dilation of superficial blood vessels. Okay, they can also suffer from splenomegaly, hemorrhage, hypertension, gout, peptic ulceration, and also erythromelalgia. Okay, so this is erythromelalgia. This is a picture of erythromelalgia in a 77-year-old woman with a long-standing PV. Okay, this is a
Doktor,
yeah.
nak tanya, gambar tadi indicate bengkak ke kuku panjang?
Nampak tak dia bengkak dan merah? Okey, ni yang normal. Ni nampak tak macam burst? Macam ada burst of blood vessels kan? Nampak tak? Yang ni normal. Yang ni yang patient tu.
Oh, kuku tu tak ada apa-apa lah.
Tak ada.
Okay.
Patient tu je. Alright. Okay, boleh beza. Tak apa jelas, saya rasa awak boleh nampak lah. Kalau awak Google dalam internet pun boleh tengok lah. Cases of erythromelalgia ni. Alright. On genetics. Mutations in the genes called JAK2 and also TET genes, they are almost always associated with PV. So it is believed that it begins when mutations occur in the DNA of the hematopoietic stem cell of these patients, and then these stem cells, they are located in marrow. They have potential to develop into all cells, red blood cells, white blood cells, platelets, and then when there is a mutation of these JAK2 genes, it actually will result in production of overproduction of JAK2 protein. Okay, and then it will constantly be turned on, constantly be activated. Okay, in the end, it will increase the production of blood cells, and then it will prolong their survival. Okay, should not be like that. Sebab semua cells ni dia ada lifetime dia kan. Sepatutnya dia ada jangka hayat dia. Dia patutnya matilah. So these blood cells, they have prolonged survival. So with so many extra cells in the bloodstream, there will be abnormal blood clots. So thicker blood also flows more slowly throughout the body, and then this will prevent the organs from receiving enough oxygen. Many of the signs and symptoms of PV are related to a shortage of oxygen in the body tissues. And function of this gene, TET2, is actually unknown, but mutations of this gene has been found in almost 16% of patients with PV. Until today, it is unclear what the role of mutations of these genes play in the development of PV, but it happens. Okay, this is the diagnostic criteria of PV. Okay, diagnosis requires meeting either all three major criteria or the first two major criteria and also the minor criterion. Okay, ada satu je minor criteria kat sini. Okay, so you can have a look. Okay, for example, the patients must have hemoglobin more than 16.5 gram per deciliter in men, more than 16 gram per deciliter in women. Okay, or hematocrit of more than 49% in men, more than 48% in women, or increased overall cell mass, red cell mass, or more than 25% above mean normal predictive value, or the patients have bone marrow biopsy showing hypercellularity, okay, the presence of panmyelosis, including prominent erythroid, granulocytic, megakaryotic proliferation, and also the presence of mature megakaryocytes, and the presence of mutation on this gene, JAK2, and also the presence of this mutation JAK2 V617F, variant 2. Saya lupa dah. Yang ni kena rujuk genetic code. So the patients must meet all these 3 criteria, or the first 2 major criteria with this minor criterion, which is the subnormal serum erythropoietin level. Okay, so we are done with PV. So usually in the lab, when the geneticist or the hematologist receive patient sample, they will refer to the criteria to make sure that the diagnosis is accurate. Bukan main teka-teka je. Just now, like PV, it must meet the 3 major criteria, or the first 2 major with 1 minor. So MM pun dia ada kriteria dia, major diagnostic criteria and also minor diagnostic criteria. So you cannot just simply diagnose them without referring to the risk stage or WHO. So it is very important. Okay, so I move on to essential thrombocythemia. Boleh? Boleh? Okay.
Boleh, Doktor.
Alright, so ET, this is a condition characterized by increased number of platelets. I think you have learned on this term, thrombocythemia. There is a thrombosis, which is very common in people with ET. It causes many signs and symptoms of essential thrombocythemia. The clots that block blood flow to the brain of these patients can cause strokes or temporary stroke-like episodes known as transient ischemic attacks. Pernah dengar transient ischemic attacks or TIA? So TIA ni, certain patients bila kena TIA, when they are affected by TIA, they lost the ability to speak. They are aware of their surrounding, but they cannot move. They cannot move, they cannot respond, but they are aware and they cannot tell the people around them that they are having this attack. TIA ni. So it's very, it's a kind of dangerous situation for those who suddenly have this attack. The thrombosis in these ET patients, they can cause leg pain if if the clot travels to the leg. It can cause leg swelling or both. And the clots can travel to the lungs, which cause pulmonary embolism, and it will block the blood flow to the lungs and will cause chest pain and dyspnea. Right. On apa lagi clinical findings. These are the clinical findings of patients with ET. Patients suffer from thrombosis, hemorrhage, erythromelalgia, which I have shown the figure just now. Burning sensation felt in hands and feet. Okay, and these patients can only relieve the pain sensation with painkiller, for example, aspirin. Splenomegaly in 40% of the patients, and also splenic atrophy in 60% of the patients, and this is due to infarction. Okay, on genetics, these 2 genes, JAK2 and also CALR, these are the most commonly mutated genes found in ET patients. MPL, THPO, and also TAT2 genes can also be altered in these conditions, and mutations of the JAK2, MPL, THPO are associated with ET, leading to overactivation of the JAK2, STAT pathway. So the abnormal activation of JAK-STAT signaling will lead to production of megakaryocytes, overproduction of megakaryocytes actually, and this will result in increased number of platelets in the blood of these patients. And excess platelets can cause thrombosis, and this will lead to many signs and symptoms found in ET patients. And this is the diagnostic criteria of ET patients. And the diagnosis requires meeting all 4 major criteria, or the first 3 major criteria and the minor criteria. So the first criteria is platelet count of 450 or more times 10 to the power of 9 per liter. Alamak, saya silap ni. This one is 10 to the power of 9. Okay. And bone marrow biopsy showing proliferation of megakaryocyte lineage. So this is not surprising because there are overproduction of megakaryocytes in ET patients' blood, and the megakaryocytes, they are mature, they have hyperlobulated nuclei, and then there are granulopoiesis or erythropoiesis, and very rarely minor grade 1 increase in reticulin fibers. Okay, and not meeting WHO criteria for BCR ABL1 CML. So yang ni maksudnya dia punya kriteria tak sama dengan CML, PV, PMF and MDS, and also other myeloid neoplasms. Okay, this one, okay, the presence of JAK2, CLR, and PL mutations. This one is very common in these patients, in ET patients. Okay, the minor criterion just now is presence of clonal marker or absence of evidence for reactive thrombocytosis. All right. So this is essential thrombocythemia. So you can see this megakaryocyte with thrombocytosis. Okay. It can also be seen in variety of reactive conditions such as systemic infections, severe inflammatory conditions, post-splenectomy state, and in those with severe iron deficiency anemia, and so on. In the absence of JAK2 V617F mutation, all these reactive conditions must be excluded. And other diagnostic criteria of ET must be met. Okay, so you have to be careful because this one not only present in ET, other reactive conditions are also there, but in order to confirm the diagnosis, okay, ET patients, they have the JAK2 V617F mutation. Okay, this is apa ya? This is also megakaryocyte. Oh, okay. Hyperlobulated. Okay. This is a large hyperlobulated megakaryocytes. Can also be seen in patients with PV. Usually, in order to complement the diagnosis of ET, the hematologist will look into cytogenetics also. Sebab dia boleh jadi overlap lah between ET and PV. So kita tengok cytogenetics also lah. Okay, so this is mature large and hyperlobulated megakaryocytes. Okay. These are young proliferating megakaryocytes. What you see is that younger megakaryocytes are also commonly seen in patients, but they have thrombocytopenia rather than thrombocytosis. And okay, that's all for ET and also PV. Any questions so far? Do you want to take a break or should I move on? This is the third MPN. Do you want to take a break or should I move
It's
on?
okay. Doctor.
I'm sorry? It's okay.
I think it's okay.
Okay, sekejap ya. Sekejap. Okay. On PMF, primary myelofibrosis. Okay, some textbooks they just use myelofibrosis, so they have abbreviated it to MF only. Okay. Sorry. Okay, PMF or MF. This is a clonal disorder. Okay. It is from neoplastic transformation of early hematopoietic stem cells. This condition characterized by build-up of scar tissue, fibrosis in the bone marrow, and then because of the fibrosis, the bone marrow is unable to make enough normal blood cells. So what happened? Okay, the shortage of blood cells causes many signs and symptoms of MF. Okay, and these are the signs and symptoms. You can see here the clinical characterization. Okay, patients will have anemia, bone marrow fibrosis or myelofibrosis, extramedullary hepatopoiesis, leukoerythroblastosis, okay, and also the presence of teardrop-shaped red blood cells. And patients also suffer from hepatosplenomegaly. Okay, and 30% of these patients are asymptomatic at diagnosis. And the major cause of morbidity and mortality is due to AML in 5 to 30% of patients, bone marrow failure due to hemorrhage or infection, thromboembolic events, portal hypertension, and also cardiac failure. Okay, so these patients are also diagnosed based on the genetics. There is also mutations in the JAK2, same as PVET just now, MPL, CLR, and also TET2 genes. All are associated with most cases of PMF. And mutations in either JAK2 or MPL are associated with PMF, leading to overactivation of the JAK-STAT pathway. So this will lead to overproduction of abnormal megakaryocytes, sama macam ET tadi. And these megakaryocytes will stimulate another type of cell to release collagen. So collagen is a protein normally provides support, structural support for the cells in the bone marrow. But in PMF, the excess collagen will form scars in the bone marrow. So mutations in CALR and so TET2 are relatively common, but again, it is unclear how these mutations are involved in development of primary myelofibrosis. Okay, so this is the diagnostic criteria. So diagnosis requires meeting all three major criteria and at least one minor criterion. Confirmed in 2 consecutive determinations. So dia strict sikit lah. First is in major diagnostic criteria. First is proliferation and atypia of megakaryocytes. Okay, there is a presence of reticulin and or collagen fibrosis. And not meeting WHO criteria for other syndromes or other disease. And the presence of JAK2, CLR, and also MPL mutation. Okay. All right. The minor diagnostic criteria is anemia not attributed to a comorbid condition. Leukocytosis, maknanya yang ni dia tak ada condition lain yang menyebabkan anemia. And then leukocytosis of more than 11 times 10 to the power of 9. Yang ni tolong betulkan sendiri. 10 to the power of 9 liter. The patients have palpable splenomegaly. Okay, boleh rasa. And LDH is above normal limit. And also the presence of leukoerythroblastosis. Okay. So patients have to meet all three major criteria and at least one minor criterion, okay, to be diagnosed as PMF. Okay, so this is peripheral blood of a patient. This is the changes of myelofibrosis showing characteristic findings of leukoerythroblastosis. There is a rare blast, nucleated red blood cells, and also large platelets. Okay, and also you can see this teardrop, red teardrop shaped red cells or dacrocytes. Okay. 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 This is dilated sinuses in primary fibrosis, myelofibrosis. It contains megakaryocytes in addition to other marrow elements. This is the megakaryocyte. Okay, so I think those are the two figures that I can show for PMF. Okay, so have you? I think there is a disease that also show teardrop shape of erythrocyte. Ada ke awak belajar dengan Dr. Saadah ke? Have you learned on teardrop shape erythrocyte before? Anyone?
Saya tak sure. Saya tak ingat. Tapi saya rasa macam ada.
Saya rasa ada satu disease yang mungkin lah Dr. Saadah yang ajar. Saya tak ingat. Boleh check balik ya, sebab saya takut awak keliru dengan yang ini. So apa-apa pun, all of this PMN disease, neoplasms or malignancy, you have to couple it with cytogenetic abnormalities in the diagnosis. Okay. Okay, so should I move on? Ada sikit je pun lagi.
Yes.
Should I move on or do you want to take a break?
Boleh move on, Doktor.
Boleh move on. Okay. Alright, MDS sekarang MDS, myelodysplastic syndrome. Okay, this syndrome refers to a heterogeneous group of closely related clonal hematopoietic disorders. So usually you can find MDS in elderly. They are all characterized by one or more peripheral blood cytopenias. So the bone marrow is usually hypercellular. Rarely there is a hypocellular marrow mimicking a plastic anemia. Okay, ada juga macam tu. And the bone marrow of these patients, they display aberrant morphology and maturation, what we call as this myelopoiesis. Okay, this one will result in ineffective blood cell production. Okay. So the median age of diagnosis is 70 years old, rarely affecting individuals younger than 50, unless the patients are preceded with chemotherapy or radiation for another malignancy. So actually MDS can happen because of this, because the patients have some kind of chemotherapy or radiation treatment because of another cancer. But MDS cases in young adults and children have been reported before. So the different types of MDS are diagnosed based on certain changes in the blood cells and also bone marrow. For example, first, refractory anemia. Here, patients with RA, they have too few red blood cells in blood. Okay, so the patients have anemia lah. And the number of white blood cells and platelets is actually normal. So patients with refractory anemia with ring sideroblasts or RARs, patients suffer from too few red blood cells and have anemia, and the red blood cells have too much iron inside, and the number of white blood cells and platelets in these patients are normal. So for patients with refractory anemia with excess blast, right, there are too few red blood cells in blood. Patient has anemia. 5 to 19% of the cells in the bone marrow of these patients are blast. And there are also changes to the white blood cells and platelets. So these patients, patients with RA, can actually progress to AML. And those with refractory cytopenia with multilineage dysplasia, these patients suffer from too few or at least too few of these two types of cells, red blood cells, platelets, or white blood cells. Not all cells lah. Less than 5% of the cells in the bone marrow are blast. Less than 1% of the cells in the blood are blast. And then if the red blood cells are affected, the RBCs have extra iron. So patients with refractory cytopenia, they can progress also to AML. Those with refractory cytopenia with uni-lineage dysplasia, patients also suffer from one type of too few of one type of red blood cell, either red blood cells, platelets, or white blood cells. There are changes in 10% or more of two other types of blood cells, and less than 5% in the of the cells in the bone marrow are blast. Less than 1% of the cells in the blood are blast. And for those with unclassifiable MDS, the number of bloods in the marrow and also blood is normal actually, and the disease is not one of the other MDS lah. For MDS associated with an isolated deletion 5q chromosome abnormality, patient has few red blood cells, patient has anemia, less than 5% of the cells in the marrow and also the blood are blast, and there is a specific change in the chromosome. And for those with CMML, yang ni quite complicated. I think I have to give you a summary on this. I will give you later through email. Okay. So for RA and RARS, RA and RARS, they are characterized by 5% or less myeloblasts in the bone marrow. So RAS is defined morphologically as having 15% of erythroid cells with abnormal ring sideroblasts, okay, and also abnormal accumulation of iron in the mitochondria. So both of these RA and RARS, they have a prolonged clinical course. They have a low prevalence of progression to acute leukemia. And for RAIP, and also for RAIP ni, it is characterized by greater than 5% myeloblasts, and the higher the percentage of myeloblasts present, the shorter the clinical course, the closer the disease to AML. Right? Saya tak ada yang ni. Okay, so what is this? So this is morphological abnormalities based on figures. Okay, this is using Leishman stain. Okay, you can see erythroid dysplastic changes here. Okay, this is megaloblastic changes. Okay, cytoplasmic fraying, internal nuclear bridging. Okay, upon blood stain ini, and nuclear lobulation. Okay, yang ni pun sama, nuclear lobulation. Okay, this is the presence of karyoraxis. Right. Ada lagi ke? Yang ni number 2. Okay, so this is hypogranulation band neutrophil. This is pseudo-Pelger anomaly. Okay, and nucleus ring or donut shape. Yeah. Okay, for J, this is megakaryocytic dysplastic changes. Ada banyak megakaryocytes. Yeah. This one is hypersegmented. This is micro megakaryocyte, and also the presence of giant abnormal platelet. Okay, so this is the diagnosis and classification of MDS. Quite complicated, tapi saya boleh guess lah. Boleh nampak bridging sini. Ini ada 2 bridging, yang ni abnormal. Yeah. This one is what we say as pseudo-Pelger. Yang ni bentuk ring. Okay, yang ni donut shape. Boleh guess semua ni. Right. Okay. So this is an example of hypercellular core bone marrow biopsy. So this patient is 70 years old. The hypercellular bone marrow is actually seen in many patients with MDS. Okay. Oh, this is the Pelger anomaly just now. The peripheral blood smear shows a hypolobulated neutrophil, what we call as Pseudo-Pelger-Hewitt cell, which is often seen in patients with MDS. Okay, so this is bone marrow aspirate. Okay, showing this erythropoiesis in the form of abnormal erythroid precursors. Okay. This is also a characteristic of MDS. Alright. So this is also an abnormal eosinophils in this image. Okay. That can be seen in patients with MDS. Okay. And also, okay, this is an example of dysplastic erythroid precursor, also seen in patients with MDS. Okay, so upon morphology of this image, it has to be coupled with cytogenetics also. So this is the cytogenetic prognosis of patients with MDS. According to IPSS-R or Revised International Prognostic Scoring System. So MDS prognosis is calculated by utilizing this system, which includes cytogenetics analyzed categories, in addition to number of cytopenias and also counting of blood percentage. So the presence of more than 3 chromosomal abnormalities will indicate very poor prognosis. So you can see here the categories, prognostic categories: very good, good, intermediate, and also very poor. So here, those with very good prognosis, okay, they have a deletion 11q, deletion of the long arm of chromosome 11, and also deletion of chromosome Y. Okay, so patients with these chromosomal abnormalities, they have a median survival of 60 months. Lebih kurang 5 tahun lah. Those with good prognosis have either normal cytogenetics or they have deletions of the chromosome 5q or double aberrations of including deletions 5q, 12p and also 20q. So the median survival is around 40.5 months. Those with intermediate, they have all of this. And poor, you can see here, poor, they have inversion of chromosome 3 and or translation of chromosome 3q and deletion of chromosome 7, deletion of chromosome 7 or 7q, and double aberrations including deletions of chromosome 7 or 7q, and complex karyotypes with 3 abnormalities. So the median survival of these patients is around 1 year and a half. Those with very poor prognosis, they have a very complex karyotypes. These patients have more than 3 abnormalities in one karyotype, and the median survival is around 6 months. Okay, yang ni boleh faham Dah belajar ke tentang ni? Saya tak tahu dah belajar ke belum in genetics all these inversions. Dah belajar ke? Can I have a response on this? Have you learned on this deletion, inversion, isochromosome? Dah belajar ke?
Doktor tanya tentu dah belajar ke?
Apa dia?
Doktor tanya pasal term tu ke?
Terms.
Dah.
Dah Yang saya tulis ni, kalau yang saya tulis macam ni, plus 8 point I. Faham ke? Yang ni ada tak? Ada tak lecturer yang ajar?
Tak ada.
Dalam genetics ada tak dia perkenalkan nomenclature ni?
Rasanya tak ada, doktor.
Tak ada. So kalau saya tulis macam ni, you faham ke? Kalau tak faham, tolong rujuk.
Tak faham.
Tolong rujuk buku teks Kalau macam ni isochromosome, the presence of isochromosomes, I'm not sure whether you have learned on this or not. Sepatutnya dah belajar dalam genetics tapi kalau belum lah, boleh tengok buku teks saja ataupun saya rasa banyak je website yang perkenalkan tentang nomenclature, genetic nomenclature. So del meaning deletion, boleh 5q long arm of chromosome 5, 12p short arm of chromosome 12, boleh Kalau saya tulis macam ni 7q minus ni maknanya deletion of long arm of chromosome 7. Okay. So plus 19 meaning gain of chromosome 19. Maknanya the whole chromosome 19 tu dia ada lagi satu set. Boleh? Boleh faham
Boleh.
Faham complex karyotypes maknanya karyotype kita tu kita ada berapa kromosom semua sekali? Ada berapa?
46.
46 kan? So complex karyotypes with more than 3 abnormalities maknanya karyotype itu akan show more than 3 abnormalities. Katakan gabungan yang ni, gabungan inversion, deletion of chromosome 7 and then dia ada double aberrations lagi. Lepas tu dia ada yang lain lagi. Boleh faham? Maknanya dia ada 3 more than 3 abnormalities in one karyotype upon karyotyping lah. Boleh faham
Boleh.
Okay. So median survival ni boleh faham ke? Median survival maknanya berapa lama dia boleh hidup lah. Median saja, bukan maknanya dia ambil kira semua patients dan ambil just median sajalah. Boleh faham yang ni?
Faham.
Okay, prognosis faham? Prognosis faham Maknanya tak semua cancer patients ni dia ada poor prognosis. Ada yang ada good prognosis, ada intermediate prognosis So yang ini deletion, those with deletion of long arm of 11, chromosome 11, those with deletion on chromosome Y, dia ada benefit. Okay, dia punya median survival dia boleh prolong up to 60 months upon diagnosis. Boleh faham
Oh, mana?
Okay. So, alright. Saya say itu saja kot. Ada lagi? Tak ada dah. Okay. Sorry, saya baru tanya sebab saya ingatkan, sebab semua senyap saya ingat boleh faham yang saya tulis satu genetik nomenclature ni. Kalau tak faham kena rujuk siapa yang ajar genetik? Dr. Saiful kan?
Doktor, betul.
Sebab dulu memang saya ajar yang ni, tapi saya rasa lepas tu saya serah pada Dr. Madia. Saya tak sure you all dah belajar belum. Dulu memang saya ajar nomenclature ni. Ada Dr. Madia ajar tak? Mungkin Dr. Madia ada ajar ke? Kalau tak sure boleh tanya dia. Okay. So kita dah habis lah. Sekejap je ni. Sebab sikit je pun yang ini. So any figures you can get from the textbooks. If you're not sure how abnormal eosinophils look like, how megakaryocytes look like, you can always refer to any histopathology textbooks or haematology textbooks if you're not sure. Okay. So yang ni saya cuba tunjuk satu-satu. Macam ni, yang ni hypercellularity dalam bone marrow lah. So, do you have any questions so far? Saya boleh stop sharing. Any questions so far? Ada? Semua join ya hari ni? Semua join hari ni? Ke ada yang tak dapat maklumat? You are 39 of you. 39 or 40 of you?
40.
40. Okay. Student yang tak dapat hadiah tu minta tolong dia bagi email kat saya.
Doktor yang tadi tu dia masuk.
Boleh masuk.
Kita tunggu appointment dia masuk.
Okay, alright. Okay. So, nothing to ask do you have any assessment after this?
For hemato, doktor. Or what subject?
Apa dia?
Untuk subjek apa tu doktor?
Subjek ni ada assessment.
Ada mini test tu dengan case study by Dr. Fuad. Lepas tu mini test tu.
Okay, case study tu bila
Case study dia dapat soalan tapi hantar 31 hari bulan.
Oh, okay. Alright. Okay. Itu je lah. Alright. Ini last lecture. Okay, so I wish you good luck for your mini test too. I wish all the best. I know there are many assignments in hematology. We are trying to our very best to reduce, but unfortunately not much that we can do. I hope you can bear with the workload. If you have any problems, please speak to your year coordinator. Siapa year coordinator Doktor apa Oh, you are year 2
Yes, doktor. Year 2 second.
Year 2 coordinator siapa? Boleh bagi tahu pada year 2 coordinator if you have any problems in executing your assessment or anything lah, any problem, so that we can discuss when we have any department meeting lah, Okay. So I guess I will end our session today. Boleh?
InsyaAllah boleh doktor.
Alright, okay.
Thank you doktor.
Alright, thank you very much. Saya lupa nak buka session tadi, masya-Allah. Tak apa, kita end the session juga lah with Farah. Surah Al-As. Okay, thank you very much. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Doktor.
Thank you, doktor.